Hello friends, I am Dr. Raktin and I am here to discuss on the topic of viral hepatitis. Let us begin. Viral hepatitis is a common terminology. It is used for a similar clinical disease, but the etiologically and the epidemiologically the diseases vary. There is a spectrum of diseases where we will find a similar set of signs and symptoms. However, the etiology will be different. Those diseases are grouped under viral hepatitis. It is caused by hepatitis A, B, C, D, E, G, and very recently, hepatitis G has also been discovered. Hepatitis A and E are caused by contaminated food or water. Hepatitis B, C, and D are caused by the exposure to blood or body fluids. One thing we have to remember is hepatitis D cannot be in isolation. It is dependent on hepatitis B virus. So, if a person has hepatitis D, then the person will also have hepatitis B infection. It may occur as co-infection or a superinfection of hepatitis B virus carrier. Now, let us discuss one by one. The firstly, we will discuss about hepatitis A. Hepatitis A is caused by hepatitis A virus. It is an enterovirus. It was formerly known as epidemic jaundice or infectious hepatitis. The clinical features include the constitutional symptoms like fever, chills, headache, nausea, vomiting, generalized weakness. There may be anorexia. The patient may pass dark urine and there is jaundice. Since it is seen mostly in children than in adults, it is mostly asymptomatic. Numerous subclinical or asymptomatic cases are found of viral hepatitis A. The case fatality rate is very low, it is around 0.1% only, and it usually results from acute liver failure. That too, the fatality is seen mostly among adults. It is very rarely seen in children. Coming to the problem statement of viral hepatitis A, since viral hepatitis A is an enterovirus infection, it is endemic to many developing countries, including India. The reasons is, is obvious that in developing countries, there is poor sanitary conditions, there is low socioeconomic group people living in filthy environment. There may be urban slums, there may be uh, water collection, water logging, sewage and solid systems are not developed, and these are the conditions which gives rise to high incidence of hepatitis A cases. The exact data on the prevalence of hepatitis A in India is not known. The reason for that is, say, in developing countries like India, 90% of the children are exposed to hepatitis A infection by the time they reach 10 years of age. And they may, in fact, uh, acquire hepatitis A infection. And in case of children, it is either asymptomatic or subclinical. The outbreaks are not do not occur. So, as the outbreaks do not occur and the symptomatic cases are also uh, that not that much. So the exact data on the prevalence of hepatitis A in India is not documented precisely. However, when there is epidemics, these are slow growing in nature and it involves large geographic areas. And when it occurs, it lasts for several months, affecting the adults and children both. Moving forward to the epidemiological determinants of viral hepatitis A, number one, the agent factors. It is caused by the hepatitis A virus, which is an enterovirus, as discussed, and it belongs to Picornaviridae family. It is good that there is only one serotype which is known to cause viral hepatitis A in men. The virus, however, is very resistant. You may imagine that the virus can withstand a temperature of 60 degrees Celsius for 1 hour, or it can survive for 1 week in well water, and it is even resistant to low pH or many of the chemicals that are used to disinfect. But the good thing is that the human cases or the carriers are the only reservoir of infection of viral hepatitis A. Continuing our discussion, the cases, however, are mostly asymptomatic when it involves only the children, and it tends to be more severe when the adults are involved. The asymptomatic cases, as I said, is mainly seen in children, and they maintain the chain of transmission. When there is no outbreak in the community, the children who are not vaccinated are responsible to harbor the infection. When the children are not vaccinated, they are asymptomatic and they are harboring the viral hepatitis A infection in them. They are the sources of transmission later on. The children, however, do not show any evidence of chronic carrier state. It is the chronic carrier state is only seen in among adults. The children are least affected. They are mostly asymptomatic, so they are responsible for the chain of transmission. Period of infectivity is 2 weeks before and 1 week after the onset of jaundice. Infective material mainly is the man's feces. Other infective materials include the blood, serum, or other fluids. It may also get transmitted by urine or nasopharyngeal secretions. But we have to remember that the feces are the most important infective material for transmission. You can imagine from the fact that the virus is shredded in the feces 2 weeks before and even 2 weeks after the onset of jaundice. Such is the infectivity for the feces. Now, moving forward to the host factors, as I said, the children by the age of 10 years, 90% of them are infected. However, they do not show any sign and symptoms. The sign and symptoms are only shown in severity in case of adults. So we can say that the clinical severity is directly proportional to the age. Both the sexes are equally affected with viral hepatitis A. One episode generally provides lifelong, but in some cases, in 5% of the cases to be precise, a second attack may occur. Most people in the endemic areas acquire immunity by subclinical infection, that I have mentioned it in my previous slides, just like when I said that 90% of the children are infected by the age of 10 years. Moving forward to the environmental factors now. In India, the viral hepatitis A is generally seen during heavy rainfall. The factors, as mentioned, were the poor sanitation, overcrowding, okay, filthy environment, water collection everywhere, the sewage and sewage disposal is not proper, insanitary habits, not enough hand washing, low socioeconomic status. These all favors the spread of viral hepatitis A infection in the community. Mainly, the route of transmission is fecal-oral. However, parental transmission of hepatitis A is there, but it is very, very rare. It may occur due to blood when it is in a stage of viremia. Sexual transmission of hepatitis A may also occur among the homosexual men because of the oroanal contact. But these are the rare transmission routes. The major transmission route we have to focus on is the fecal-oral route of transmission. Moving forward to the clinical picture, the incubation period of viral hepatitis A is 10 to 50 days. Usually it takes 14 to 28 days. Onset, as I said, it starts with constitutional symptoms of fever, malaise, nausea, vomiting, anorexia, and weakness. Jaundice may be appear, but anicteric phase is more. Since why anicteric phase is more common? Because it involves children mostly, and they are mostly asymptomatic. When adults are involved, they are symptomatic, and then you may find jaundice in them. 98% cases resolve, but sometimes they may relapse. Like I said, 5% of the cases, there may be second episode of viral hepatitis A. The case fatality rate was also very low. It was only 0.1% and mainly affecting adults. Diagnosis. It is by the blood picture, where there you will find abnormal liver function tests, raised serum alanine aminotransferase, ALT, bilirubin and the thyroid bilirubin thing is raised. Specific laboratory diagnosis of hepatitis A is by demonstrating it in the stool sample. ELISA, on the other hand, we will find anti-HAV IgM in the acute stage, and it declines with time, like 3 to 6 months. The IgM antibody level of THAV declines, and from there the IgG titer of anti-HAV appears, and it remains for a long time. With this, we can diagnose the hepatitis A infection by laboratory parameters. Moving on to the prevention and control, we will discuss under the following headings. Number one, the reservoir control. The reservoir control is very difficult to. The reasons are cited below. The fecal shedding is mostly during the incubation period, and it had a long incubation period of 10 to 50 days. It is generally said of 14 to 28, but however, uh, it may persist for 50 days. So it is very difficult to control. Secondly, there are large number of subclinical cases in the community, mostly the children. So the control of the reservoirs is very difficult. We may not know which uh, person is a case or a carrier. On top of that, there is no specific treatment of viral hepatitis A. These are all symptomatic treatments. And lastly, this disease occurs mainly in low socioeconomic class people, and they generally are uh, neglected in the society or from the system, and thus the control measures becomes difficult. But to discuss the control measures, adequate bed rest is very important for the cases or any symptomatic persons. Number two, it should be a routine or a measure should be taken where there should be routine disinfection of the feces by sodium hypochlorite solution. It will help in disinfecting the uh, feces and ultimately leads to the break in the chain of transmission. Moving forward to the control of transmission now, it is very simple. It, it is with personal or community hygiene. Few of the examples are hand washing. We generally tend to avoid the hand washing, but hand washing is very important, like we saw it in coronavirus infection. Similar is the case with hand washing before and after using toilet, before and after having our meals. This simple step of hand washing, if performed adequately, will prevent half of the foodborne diseases in man. Secondly, the sanitary disposal of excreta. The sanitary disposal is very important because when there is insanitary disposal, there may be chances of contamination of food, water, milk, etc., and which leads to the food or waterborne infections in the community. Thirdly, the purification of water is important to control the transmission. Why I am saying so is because with flocculation, filtration, and chlorination, the hepatitis A virus dies. So there will be lesser chances of transmission of viral hepatitis A in the community, ultimately leading to the prevention and control. Lastly, the proper disposal of sewage. Sewage, we know that the waste mixed with excreta. These are the places where hepatitis A virus is present. If we dispose of the sewage properly, then there would be lesser chances of hepatitis A virus survival and ultimately the transmission will be halted. Moving forward to the control of susceptible population now. As for the susceptible population, we have to first focus on the targeted population of high risk groups. The targeted population of high risk groups, with that I mean the travelers. Number two, the injectable drug users, chronic liver disease patients, travelers, because if the traveler is traveling to one endemic country or a place where there is hepatitis A, then the traveler should take the preventable measures, the control measures, or the prophylactic measures to save himself or herself from acquiring hepatitis A virus. Secondly, the injectable drug users, the female sex workers, men having sex with men, those population are also susceptible of having viral hepatitis A. This is because even though viral hepatitis A is a enterovirus, because of their high risk behavior, there may be chances of parenteral transmission of viral hepatitis A among these populations. So we have to take extra precaution in these populations. Thirdly, the chronic liver disease patients, they are at high risk because of the already deranged liver enzymes, and these patients have higher chances of acquiring hepatitis infection. Prophylaxis should be given in the form of vaccines. The immunoglobulin use, it should be discouraged because number one, the immunoglobulin, the cost is very high, the availability is very low. On the other hand, the vaccines are cost effective both to the community and to the individual. Secondly, the availability is more. We have to give more focus on vaccines rather than immunoglobulin. Now, coming on to the vaccines, there are two types of vaccines present: formaldehyde inactivated vaccine and live attenuated vaccine. The inactivated vaccines is administered to persons of more than 12 months of age. So, when a child of 1 year, that child may be given the inactivated vaccine of hepatitis A. It is given intramuscularly in two doses at an interval of 6 to 12 months. And more importantly, this vaccine can be given with all other vaccines, can be combined. That was about the inactivated vaccine. Now, the live attenuated vaccine, on the other hand, is given in the single subcutaneous dose. Now, coming on to the viral hepatitis B. Viral hepatitis B is acute systemic infection. It is causing both acute or chronic, asymptomatic, mild, severe, or fulminant hepatitis. It is otherwise a self-limiting disease, but chronic hepatitis may occur. Viral hepatitis B is marked by acute inflammation and hepatocellular necrosis. Now, one line about the chronic hepatitis is that when we say chronic hepatitis, Chronic hepatitis is defined as persistent hepatitis B virus infection, and it may be with or without acute viral replication. Along with that, there will be evidence of hepatocellular injury and necrosis. It may be deadly when it is allied with hepatitis D virus. Coming on to the problem statement, it is endemic throughout the world. The prevalence is lowest in countries with high standards of living. It is highest in African Western Pacific region. However, the prevalence is lower in southeastern, eastern Mediterranean and European regions. With southeastern, I am particularly focusing on India. With eastern Mediterranean, I am particularly focusing on Pakistan. So in these countries, the uh, prevalence is little lower. It causes significant economic burden to all the countries. Lastly, I want to discuss why there is lower prevalence in southeastern or eastern Mediterranean regions is because, particularly in India, the hepatitis B vaccine is an effective vaccine. Now, as since the administration of hepatitis B in the birth dose is taken up seriously in immunization schedule, more and more number of neonates are getting vaccinated, and the immunization coverage is slowly and gradually increasing in the country. With this, the prevalence of hepatitis B virus infection in the community is gradually at a decline. And globally also, the WHO report says that the global prevalence of hepatitis B virus among children of under 5 years of age has been reduced to just less than 1%. So the prevalence is gradually decreasing. However, the symptoms are yet to be taken care of, and so an effective immunization uh, is important to control the problem of viral hepatitis B. Moving forward, coming on to the epidemiological determinants of viral hepatitis B, number one, the agent factors. It is caused by hepatitis B virus and it replicates in the liver cells. It has got three morphological forms, out of which the Dane particle is infectious to men. The other two morphological forms are not infectious to men. Man is the only reservoir of infection. So, the man may be a case or a carrier. When we say a carrier of hepatitis B, with that I mean the person has persistence of hepatitis B surface antigen with or without the replication like hepatitis B core antigen for more than 6 months. So a carrier of hepatitis B is defined as a person who has HBsAg positive with or without HBeAg. It may be positive or negative. We will term that person as carrier. Like any other hepatitis virus, this virus is also very resistant. However, it is readily destroyed by sodium hypochlorite, but it is quite stable and it can survive up to 7 days. Sterilization, autoclaving to 30 to 60 minutes also destroys the hepatitis B virus. Coming to the host factors. In host factors, age is inversely proportional to the development of chronic hepatitis B virus. With this, I mean when a younger children or the neonate is infected with hepatitis B, then the chances of developing chronicity is very high. While as the age increases, the development of acute infection of hepatitis B increases. That means age is directly proportional to the development of acute infection of hepatitis B. Okay, the high risk groups for hepatitis B virus are persons who receive blood transfusion, healthcare personnel like doctors, nurses, laboratory technicians because of their profession, homosexuals or the female sex workers, IV drug users. They are at high risk because of their high risk behaviors. Recipients of solid organ transplants, when similarly like blood transfusion, when organ transplantation takes place and it is not matched and cross matched properly, then there are chances of transmission of blood-borne infections like HIV, hepatitis B virus, hepatitis C virus. And if the person is immunocompromised, then the person may develop hepatitis B virus. They are at risk of developing it. Moving forward to the mode of transmission. Now, hepatitis B virus is primarily blood-borne infection. The perinatal transmission from the mothers to their babies occur. Now, when we say blood-borne infection, we mean that the transmission of hepatitis B occurs through the contaminated syringes, blood transfusions, dialysis, any surgical or dental procedures, even immunization, ear piercing, nose piercing, etc., tattooing may cause transmission of hepatitis B virus if not done properly. The important mode of transmission of hepatitis B is by the intimate contact or through the sexual contact or by the body fluids. Thus, I said the persons of high risk behaviors are at high risk of transmission of hepatitis B. Horizontal transmission from child to child is also responsible in Africa, but it is not that much common in Asia. Moving forward to the clinical picture, the incubation period is 30 to 180 days, average of 75 days. Again, the signs and symptoms are similar, with starting with constitutional symptoms like fever, uh, headache, malaise, nausea, vomiting, jaundice, passage of dark urine, and the wide range of presentation also includes like progressive liver fibrosis, and it may lead to cirrhosis and end-stage liver disease. These are some of the additional symptoms that you will find in hepatitis B, and which was not uh, that much common in hepatitis A. Hepatocellular carcinoma without cirrhosis may also occur, and it may be co-infection with hepatitis C, hepatitis D, and HIV. Coming to the serological pattern, it is important to know when we uh, say that hepatitis B is there in a patient. When there is hepatitis B, HBsAg positive, and only IgM antibody of hepatitis 4 antigen is present, along with hepatitis E Ag, then we will say acute hepatitis B infection. HBsAg give us hepatitis B is present or not. IgM antibody will give us whether it is acute or chronic, and HBeAg give us whether there is acute viral replication going on or not. So when the HBsAg is positive, there is no anti-HBs, and anti-HBc we will find IgG, as well as when there is HBeAg positive, then we will say that there is chronic hepatitis B. Chronic because we have found IgG antibody, and HBsAg is also present. So chronic hepatitis B is there. And since HBeAg is, I repeat, HBeAg, will say that there is acute viral replication is also going on. Thirdly, when there is HBsAg positive, IgG antibody for HBC is present, and there is also anti-HBe positive. Then we will say that there is chronic hepatitis B, but there is very low viral replication. The active viral replication is not going on. since HBeAg is not there, only anti-HBe is there. So there is low viral replication along with chronic hepatitis B. Third, now coming on to the fourth one, HBsAg, anti-HBs is also IgG antibody is present. With this, we will say that chronic hepatitis B is there. HBeAg and anti-HB, it may be plus or minus. Then we will say that it is chronic hepatitis B with heterotypic anti-HBs. Now, suppose we will find that there is no HBsAg, there is no anti-HBs also, but we found IgM antibody for viral hepatitis B, and the other two viral replication markers like HBeAg or anti-HBe may be positive and it is negative and the antibody is negative, then we will again say that it is acute hepatitis B infection. Since IgM antibody we found. Now the next scenario, when HBsAg is negative, the anti-HBs is there, and IgG antibody found. Then we will say that recovery from hepatitis B infection is taking place, and it is due to the immunity. So, when there is anti-HBs and IgG, then the recovery phase of acute hepatitis B infection, the recovery phase, I repeat, is going on. The next scenario comes is when there is HBs antigen is negative, anti-HBs is positive, and there is no IgM or IgG is there, everything is negative. So, we will say that the person is vaccinated. It is due to the immunity. When there is only anti-HBs is present and rest everything is negative. The last scenario, when everything else is negative except the IgG is there, you may suggest that it is either false positive or the infection has occurred in the remote past, a long time ago. That was all about the serological pattern of hepatitis B. With this table, I want to focus on when you find HBsAg positive and IgM antibody is present, it is acute hepatitis B. HBeAg, when it is there, it suggests acute viral replication. IgG antibody suggests chronic hepatitis B. Okay, that was all from this slide. Moving forward to the next slide, prevention of hepatitis B infection. Prevention of hepatitis B infection is by the vaccine. It is available in monovalent or in combination as pentavalent vaccine in under National Immunization Schedule. The hepatitis B vaccine is given intramuscularly in the deltoid muscle for adults and older children, but it is given in the anterolateral aspect of the thigh for children under 2 years of age. Complete vaccination will give protection to 95% of the children. In case of adults, it is given in 3 doses. For adults, prophylactically, it is given in the persons who are in the healthcare workers or who are at risk of acquiring the disease. It is also given to uh, the persons of high risk behavior. The doses are the first and the second dosage should be given in a minimum gap of 4 weeks. The second and the third dosage should have a minimum gap of 8 weeks. But do remember that the minimum gap or the duration between the first and the third dose should be minimum of 16 weeks. Thus, to make things easy, we can remember that we can give the 3 doses at 0 at after 6 months and after then the third dose after 12 months. It will fulfill our purpose. Moving forward to viral hepatitis C now. It is a contagious liver disease caused by the hepatitis C virus. It may be mild illness or it may be serious, and it is a lifelong illness. The infection of hepatitis C are at risk of developing liver cirrhosis or liver cancer. Thus, it is of concern to us. Co-infection with hepatitis B and HIV are quite common when a person is hepatitis C positive. Moving forward to the mode of transmission, it is similar to hepatitis B and the exposure is through the infected blood. It can occur through the receipt of contaminated blood or blood products or the solid organ transplants when it is not matched and cross-matched properly. Injection with the contaminated syringes, needle stick injuries are quite common and the transmission of hepatitis C occurs. In fact, it is said that the needle stick injury have a potential of transmission hepatitis C in almost 30% of the cases. It is also seen in IV drug users because of the high risk behavior of sharing the syringes. So one person, if he or she is infected, that infected person may transmit the uh, hepatitis C to the fellow persons with the use of contaminated syringes in the form of needle stick. Perinatally, the infection hepatitis C infected mother may also transmit it vertically to the babies. The diagnosis and treatment. The diagnosis is same like other hepatitis infection. But for the treatment for hepatitis C, it is interferon and ribavirin. It was given weekly injections for 48 weeks. The newer modalities of treatment include the direct antiviral agents for 12 weeks. Few of the examples of direct antiviral agents are teclatasvir, sofosbuvir, ladipasvir. Moving forward to the strategies for prevention. The primary prevention of hepatitis C. It includes number one, hand hygiene. With hand hygiene, I mean proper hand washing techniques, use of gloves, surgical hand scrub. These all prevent the transmission of hepatitis C. Secondly, safe and appropriate use of injections. Here, most importantly, we have to remember that we should not have to recap the needle. It is the most common situation where there is needle stick injury to the healthcare workers or to any others. Thirdly, safe handling and disposal of sharps. The sharps should always be discarded in white puncture proof containers. And before that, we have to treat it with sodium hypochlorite solution before disposal of. Shredding should also be done. These will help in the reduction of needle stick injury from the sharps. The fourth point is the harm reduction services. Here, uh, the persons who are taking injectable drugs are counseled and they are counseled to shift it to the oral substitutes. It is known as oral substitution therapy. In this case, the persons will have lesser chance of transmission of blood-borne infections. Fourthly, the testing of the blood and the other blood products is a routine in the blood bank procedure, and this helps in the reduction of transmission of blood-borne infections. Lastly, the condom promotion is also a strategy as a primary prevention to uh, halt the transmission of blood-borne infections like hepatitis C. Moving forward to the secondary and tertiary prevention. In secondary and tertiary prevention, the number one is information, education, communication, IEC, and behavioral change communication, the BCC, for the care and treatment. Secondly, immunization. with hepatitis B to prevent co-infection and to reduce the harm to the patients or to the community. Immunization is a must. Early diagnosis and treatment comes in the secondary prevention or as a medical management of hepatitis C. Why? Because early diagnosis will lead to early reduction of viral load of hepatitis virus in the body, and this will lead to lesser chance of transmission of hepatitis virus to others. With early treatment, there would be better survival chance of uh, the patient, and the morbidity and mortality will reduce. Regular monitoring is important because it helps us to halt the chronic liver disease. Now, moving forward to the viral hepatitis E, just like hepatitis A virus, it is a waterborne disease and mostly it is seen in the sewer water. The prevalence is highest in East and Southeast Asia. The reasons is as obvious because it is related to food or waterborne diseases and due to poor sanitary conditions, low socioeconomic class people, then more of urban slums, these or overcrowding, all these factors contribute to the higher prevalence of hepatitis E in Southeast Asian region. Transmission is fecal-oral. Blood transfusion or vertical transmission may occur, but the main transmission route is by fecal. Clinical picture and diagnosis are same just like other types of hepatitis. But thankfully, hepatitis E virus is self-limiting and recovery is always complete. The case fatality rate is very low in case of viral hepatitis E. Now, the last slide of viral hepatitis D. As I mentioned in previously, viral hepatitis D is always, it occurs in presence of hepatitis B. Transmission is same as hepatitis B. It is through the sexual route, through the blood or other body fluids, or it may be by transfusion or vertical transmission from the mother to the baby. There is no specific treatment. The only treatment available is pegylated interferon alpha. One thing to consider is it leads to fulminant hepatitis and end-stage liver disease. As I said in the previous slide, it can be as a co-infection or superinfection among hepatitis B infected patients. In this case, we have to think of liver transplantation as the only option uh, to cure the patient. That was all about viral hepatitis from my side. Thank you very much. If you have any query or doubt, please put your views in the comment section. Thank you very much. Have a good day.